welcome to this week's episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy. And Wes, when was the last time that you read a textbook? I just want to ask you. I know the answer, I think, but I want to challenge and maybe discuss this as we start the show, because this show is important, and I think it might be a little bit of kind of an opening into a door with a guest that we might be talking about a lot more. But is there a place for textbooks anymore, Wes? What do you think?
Oh man. I really think, like, John, you're calling me out hard on that. Currently, we're actively reading a textbook, and after the show, we'll tell you when we come back here in just a little bit after this special interview from the AO. And you guys missed it again. An incredible interview with George Mandelaris. Actually has became somebody that we've connected with after the show. But I emailed him the other day. I was like, man, I'm just telling you about some things. And he was encouraging me, and I was encouraging him. But George is a periodontist in Chicago, doing some pretty special stuff that we're going to talk a lot about that on the show. And we're going to talk about the textbook that we're reading and why we would be reading a textbook. Why do we read the text? But before that, John, the Dental Guys is brought to you by the Dental Crafters Network. Discover the difference, John, a relationship with the Dental Crafters Network can make. I'll tell you about the difference it can make. It makes the difference whenever your new associate comes to your practice from another practice and he says, whoa, there's a total difference here in what I was doing in the other place compared to here when it comes to my indirect restorations. Mm-hmm. And so, hey man, don't just take it from me. We've used the Dental Crafters Network, John and I, for many years prior to the Dental Guys podcast. We appreciate their sponsorship. They're a full-service laboratory guiding you towards innovative solutions that really do make a difference, and you can see the quality in the things they're providing you. The Dental Crafters Network focuses on this quality with cutting-edge digital dentistry solutions, and trust me, they are pushing and testing and making sure things are proven and planning for the future with this digital technology. Call 1-800-472-8302 today. And John, as we say, don't forget to mention the Dental Guys and get 10% off your first case.
That's right. That's a big deal. And we also want to thank one of our other sponsors, which is Restorative Driven Implants. And for those of you who are not familiar with Restorative Driven Implants, or RDI as we call it, this is the real deal. This is the way to implement dental implants into your general practice. If you've been thinking about, hey, I really want to get into implant dentistry more, but I want to do it in a way that I will be successful. I want to do it in a way that will be systematic. I want to do it in a way that is based upon research, the way that Wes and Jon talk about things, the way that the Dental Guys would think about how to learn or how to teach implant dentistry. This is a place to start. Restorative Driven Implants will help you to understand the basics all the way through to the advanced and complex ways of dealing with implant dentistry. So if you're interested in this, adding this to your practice, or maybe you're already placing implants and you want to take it to the next level with some more advanced courses, go to restorativedrivenimplants.com or call 715-207-6587. That's 715-207-6587. And make sure you mention the Dental Guys when you call Restorative Driven Implants. Thank you to RDI for being an ongoing sponsor of the Dental Guys. And now to the main part of our show, Wes. When I asked you about the textbook, I want to really dive into when we spoke to George Mandelaris at the Academy of Osseointegration Meeting this just a few months ago. We came in knowing that he was influential in the AO and the perio world. We knew this. He was involved with AAP, involved with AO, has published a lot of interesting things, but I don't know that we really understood until we spoke to him how much of a leader he was in creating a collaborative effort with other specialties on airway and especially on surgically facilitated orthodontic treatment, SFOT, MARPE, how it compares and how periodontists can become more involved in doing the types of procedures that might help these patients that need airway-focused therapy. So the conversation, I think you'll appreciate it. It starts with more of just kind of what's messing with you, right? That's been the theme of the Dental Guys in 2024. And I think Dr. Mandelaris really brings it clearly through as to what's been messing with them this last year. And after this interview, Wes, we're going to come back and talk about how did this change the way we think about things in our practices, and maybe did it cause us to look again at the value of textbooks. So without further ado, here is Dr. George Mandelaris from the Academy of Osseointegration Meeting, Annual Meeting 2024.
Well, welcome to this special episode of the Dental Guys podcast. I'm Wes the Dental Guy.
And I'm John the Dental Guy. And we, of course, are back with you from the AO 2024 meeting here in Charlotte. And this is the place to be. So if you're listening to this, again, with the FOMO, the fear of missing out, you've missed out on something amazing, but we're going to try to bring you the best we can. Some of the highlights of some of the smartest people we know in dentistry are here and are giving us kind of what's next. And again, the meeting kind of theme has been going beyond the boundaries. Wes.
Academy of Osseointegration has done a great job bringing together people over the years that have interest in, from the implant to the bone to pathology that we really don't understand yet. Even in this, we're studying about periimplantitis, perimucositis. But today, this is a very special guest, John. Something that has been near and dear to our heart is really the diagnosis of the patient, really understanding before we get into regeneration procedures like putting teeth back. And sometimes we need to step back, take a look. Where's this patient been? How did they grow? How did they get where they're at right now?
Well, and a lot of how we were trained, because of course, those of you who've listened, we were big Spear fans over the years, right? So facially generated treatment planning is sort of where we began. So it begins with the face. And so our next guest, I think, is going to be able to kind of maybe bring that full circle from, the micro to the macro level. So we'd like to welcome Dr. George Mandelaris. Thanks for being with us.
Thank you, guys. Yeah, it's great to be with you.
Glad to have you. And of course, I think where our discussion started as we were preparing for this today was we knew that you had been instrumental in writing a book on surgically facilitated orthodontic therapy, SFOT. And that's something that I want to maybe start with that simply to introduce maybe some of our listeners who don't know you as to what is that all about, and then how does that fit into maybe some of the discussion we're going to have today about diagnosis and the patient? And we got into some of this before the show about the face. Just kind of talk about some of your research interests with that, and how did that book come about?
It's been quite a journey. It was kind of an evolution. It started with really my kind of partner in crime, Brian Vence, I think just an incredible savant, restorative dentist, and his relationship with Rick Robley and kind of understanding what Rick was doing through the Aesthetics Academy, and said, look, this is the future of perio. I need you to start doing this stuff. It's really interesting. And at the time, we actually weren't even thinking about, airway issues and nasal volume, nasal resistance, and all these things, and MARPE wasn't even on the radar screen. But we were looking at how can we not necessarily accelerate tooth movement, but how can we develop phenotypes. And invariably I was seeing all these patients. So initially when I started learning this, I thought, man, orthodontists are just going to start flooding my offices with patients. I mean, how do they not see this stuff? But it just never happened. And so what would happen is I would basically be getting these patients for recession, and invariably they have a malocclusion. And so I would start to kind of send patients to the orthodontist saying, hey, we have recession issues, but they also have dental alveolar deficiencies. We want to kind of correct the malocclusion. Maybe they'd have some missing teeth, so they also needed guided bone regeneration therapy. So it all kind of tied into a dental alveolar surgery that was somewhat, perio-driven, that was somewhat interdisciplinary driven, and it kind of fit into the wheelhouse of perio that was now kind of expanding the scope of the profession. And then as things evolved, we started looking at this isn't really a substitute for orthodontic surgery. It is definitely improving the phenotype of patients. It's also combining therapies that we need for implant site development. It's positioning the patient really optimally. And it also went back to restoratively driven. So all these patients that had wear, and compensatory eruption, their teeth were getting smaller, right? And so you had to kind of intrude and expand.
Yep.
There's no bone to expand, okay? And then put the intrinsic proportions back in the teeth and then close everything. So to do restorative dentistry more elegantly and more minimally invasive and at just a more ideal level. And that was really the context. So not a substitute for orthodontic surgery, but certainly a complement for decompensating these patients, particularly those that need orthodontic surgery, maybe for sleep apnea problems, could get them there faster and could get them in a more meaningful way.
Yeah, and so for those of you who might not know what SFOT is, so maybe just to define that a little more, because I think a lot of us in dental school, even if we're just GPs, we learn about orthodontic surgery. We know something about it, and I think as we've expanded, and those of you listening to the show for a while are very familiar with SFOT and MARPE, because this is the things we talk about all the time. But let's maybe define that for our listeners who aren't as familiar. So what does that sort of look like surgically? What are we doing with SFOT? And then maybe we can start to talk bigger picture about how we compare that to MARPE, to these other procedures, and where does it fit in? So kind of talk through that. Define that for us a little bit.
So the acronym SFOT is really surgically facilitated orthodontic therapy. That is really the definition of that is corticotomy assisted orthodontia. So what is a corticotomy? A corticotomy is basically an incision in the cortical bone. So you're making basically vertical incisions adjacent to the tooth roots, and oftentimes apically, at least 5 millimeters below the apex of the tooth, so you don't sever pulpal blood supply. And then dental alveolar decortication. So you're doing the vertical slits and the dots, basically you're decorticating teeth. And you're basically trying to simulate fracture injury to the dental alveolar complex, because that then results in a demineralized bone matrix, or what we call the regional acceleratory phenomena. So now you have a demineralized bone matrix, and if you happen to have braces on the patient's teeth or aligners or something like that, now the orthodontist or whomever's moving the teeth can move the teeth without all the resistance to tooth movement. So the teeth move much more expeditiously, right? So 50% faster. Because most of the CBCT studies show us that the facial bone volume, on average of humans is about 1 millimeter. It's not a lot of real estate to move teeth. And when you have a patient that's already compensated because they have a skeletal imbalance, now you don't have a lot of room to move the teeth. Well, if you're just looking at Invisalign if you're just looking at a cartoon that shows gums and teeth, and here's now, crooked teeth and here's now straight, it doesn't give any respect or really any fundamental understanding to what is the influence of tooth movement on the dental alveolar complex? What's the influence of that on the...
And you're often augmenting at the same time, correct?
Yeah,
because you have to expect as you're expanding that if we already have not a lot of bone and tissue, often these patients presented to you with recession, as you said, as a result of being kind of compensating for the skeletal deficiency. So at the same time of doing the corticotomies, doing and this wrap phenomenon, you're also going in and augmenting both bone and soft tissue often. Is that correct?
Yeah, more so bone. Oftentimes, if a patient has a really thin gingival phenotype, then we will, I will perhaps do a 2-stage surgery where we will kind of convert the deficient gingival phenotype to one that's more robust, and then come back and do the surgery. Because oftentimes, if you're trying to do too much at one time, it's like Dennis Tarnow says, one miracle at a time. If you tear the tissue or something, then you're going to compromise the bone augmentation results. So we will oftentimes augment first and then come back and do the bone morphotype change. But many times it could be simultaneous.
Yeah, the confusion I think with a lot of people, and we use tooth movement to gain bone when we're moving teeth in certain directions.
Totally.
So especially we've seen cases, even rehab cases, where we're looking like, let's hold on to this tooth and then erupt it to pull bone and soft tissue with us so that we have more bone. We're actually doing grafting with teeth in that way, pulling a tooth down coronally. This is different, though. We're moving teeth into an area where that doesn't happen. Speak to that and why we would be concerned about this, because
how far can we push this?
How far can we push
Because there's a blood supply limitation. There's a bony housing limitation, correct?
Yeah, and you know, you can't, you know, I remember cases that I first started doing, it was like, I look at the photos now and I think it's like chicken scratch. I wasn't even getting into the marrow, you know, and so it is, you know, it's a beautiful blend of perio, which is sophisticated in opening and closing, but then, you know, then it also transitions to kind of more of an oral surgery type of a program with the large scope type of surgery and the real, you know, being a little bit aggressive to do what you need to do to have the impact that you need to have. So depending on the extent of expansion, I would say, you know, you could certainly get, you know, 2-3 millimeters. 4 is probably pushing it a little bit, but I think, you know, 2 to 3. But, you know, we work in millimeters, and at the end of the day, you know, everything we do should be restoratively driven, right? And so if there's a implant need, or if there's a, you know, rehabilitation need of the patient, you know, the best way is to kind of get an orthodontic setup and a diagnostic wax-up done, and then know, like, how far are we going. And if we can bridge this to a CBCT software program, SureSmile is an example of one, then you can really kind of see, okay, what's the risk assessment here? Just because we see dehiscences and fenestrations on a scan doesn't necessarily mean we have to jump in and do all this surgery. But if you really kind of are making a big impact on the patient, you're really kind of moving those crowded teeth, then, you know, then there's probably going to be some deficiencies in the bone volume. And that's the biggest issue. I think when you see crowding, think dental alveolar deficiencies.
That's right.
Think not enough bone around the teeth.
We are keenly aware that a lot of patients are dealing with these issues right now, adults, adolescents, and we talked before the show about co-diagnosis. And what that's really led to, as far as before we even get to the surgery, right? Talking to the patient about certain things that are maybe really kind of under the radar when it comes to medical professionals.
Yeah, and what's interesting is you said you kind of expected, once you knew about this surgery, that you would be flooded with patients from orthodontists, and yet it didn't happen. And there's this bigger picture idea that we want to maybe have you touch on, is why are we not having more awareness of, and SFOT is one tool, right, in the toolbox.
Totally.
There's obviously multiple other tools which we can touch on, but where do you think some of those limitations are? Is it education? Is it feeling like the orthodontist, because we feel like, we've talked to Rebecca Baca a lot about this, for instance, on, you know, seeming aggressive, maybe this perception of this is more aggressive treatment because the word surgery maybe gets mentioned, or TADs get mentioned, or whatever. So speak to a little bit of that, of the co-diagnosis. What do we need in our profession to sort of push this idea forward?
You know, so a lot of times people ask me, like, how do you do all this procedure? You know, you can't see a patient for a 1-hour consultation and have all the answers. And the unfortunate thing in our profession is we don't get paid to diagnose. We don't get paid to plan. And that is the most important thing, and plan in a interdisciplinary team fashion. I mean, that is kind of the core of our practice, is really building bridges and planning as an interdisciplinary team. So I think one of the biggest things is to kind of realize that you don't have to have all the answers when you meet somebody for an hour, hour and a half, because there's usually so much, you know, you have to process and think through so that you can make a meaningful impact on that patient's life, so that you can create sustainable oral health conditions for a lifetime. And that means, you know, looking at the perio, the caries risk assessment, the craniofacial phenotype, and then also paying attention to the nose and the upper airway, and looking at, you know, are the nasal apertures symmetric? Does a patient have a collapse? Is their septum deviated? I can tell you that if they have a crossbite, they're probably going to have some sort of septum deviation. And if you just subject yourself to, like, you know, the nose score and these subjective analysis, the problem is patients are like, they compensate, like, I breathe fine. It's no, you know, I feel fine. I'm like, and then, you know, you throw a pulse oximeter on them, an HRPO or Y, and you see their their cycling time is high, and so you start to, this is not diagnostic, but you start to dig deeper and you start to say, well, here are some things that I see. So, it does take a bit of thinking, a fair amount of planning, but then you start to kind of get other people around you that kind of are reinforcing what you're seeing. Mm-hmm. And the patient starts to kind of say, well, what can I do about this? How can I manage this? So one solution might be MARPE, might be, hey, let's change the nasal flow resistance, and maybe MARPE would be a better way than cutting your turbinates out. Maybe a better way of kind of not just making more room in this room. You have to make the room bigger. Yes. You can't just clear out the tables and everything. The room is still small. You have to kind of expand the room. And so that is certainly, I think, a total game changer in our profession, and certainly in the orthodontic profession. It's creating more beautiful smiles. Yes. It's creating better occlusions. It's and hopefully creating healthier patients. And that's what we need to study. Key. We need to study that. Yes. And we need to study it medically. We need to study what's the impact on the heart rate, what's the impact on the autonomic arousals. What are these things happening? And if you're going to expand somebody with MARPE, how do you now coordinate the lower arch? Yes. Right? Yes. You can't throw a MARPE on the lower arch, and you have dental alveolar deficiencies on the lower. But
it seems like even starting with recession, which is, I think as we've learned more about this and we start to think about the etiology of recession, we have often minimized that to, you're brushing too hard, or, we need to be more careful with, what toothpaste we use, but as it seems like, and you're sort of, I think, down the same road too, that it should be maybe an indicator that there's a problem here. We have a discrepancy between available bone and tissue and the teeth, and maybe even the whole jaw complex.
Totally. Those are factors that we do need to consider. Of course. For sure. Look, the American Academy of Periodontology, and I was on these best evidence consensus papers that were, we've changed from looking at patients just from a recession standpoint. We look at it now from a phenotype-driven treatment planning standpoint, right? So the gingival morphotype or gingival phenotype, which is the thickness of the soft tissue and the amount of keratinized tissue width, and then the bone morphotype, is it less or more than a millimeter? So the profession is changing. The other thing that we need time to kind of step back and look at is to also consider the back of the system, like the joint. Right, so many patients are posturing forward, or they're fulcruming, right? And so now what's happening? You get a fractured tooth, and there's a vertical defect, so we're going to take the tooth out, or we're going to graft it, and they still fulcruming, right? Yep. So we're going to put an implant in, and they're going to be fulcruming on the implant. So, and when you correct the fulcrum and you get the visceral tissue out of the joint and you get the joint seated, what happens? Well, the patient's more class 2. Right. How are you going to fix the class 2? Are you going to do a bilateral split on somebody who has a 2 or 3 millimeter overjet? Are you going to dump the teeth way forward?
What you're talking about here is not reactive medicine. And we in dental school, as technicians, the first thing is to learn the process of actually using technical things and doing a technical procedure many times. And we're taught, this is a class 1 composite, this is a class 2 composite. Then that leads to, this is what a perio probe does, is 1, 2s, and 3s are great. We're so quantified. But then when you step into that, you're like, we're very reactive. We react to symptoms. We react to what we see. And so much of this is proactive, and so much of it has been missed because we weren't proactive. Where do we go from here from a standpoint of working with a team? The teams that John and I've developed and worked around, it's really, we feel blessed, but I know that you've run into some battles. You had to have had maybe finding the people that really want to be proactive or look at things in a different way, because there is resistance in this realm. I want you to speak to some of that.
So my buddy Brian, he always talks about dogs bark at things they don't recognize.
That's good.
So you don't know what you don't know, and I think until we get the body of evidence out there that shows that, hey, this is going to make an impact. I still struggle with that, because I examine a patient, they have 0 symptoms, and it's like, what is the value of going through all this treatment if I don't have any pain? It's like, well, okay, do we want to wait till you get TMD pain to now start and maybe lose a tooth or have all these dental issues, to start, to develop a more complex plan. And I think it goes back to language. I think it goes back to how you communicate with the patients and really figure out, what are they looking for? What is their situation in life? What are their goals and aspirations? I mean, how do they want to, develop their dental personalized plan? It's complicated, and we don't have human resource departments in the dental in our dental clinics.
But I think, like you say, it's a combination of, for some people, it's, they just have to see the evidence, the body, and there's obviously a lot of work being done on this now, as opposed to, 10 years ago, this was a, we thought we knew things, but we weren't sure. It seems like that's moved a long way forward. But I just remember as we were going through our training again at Spear, we started off in the middle of this where we were looking at, posterior interferences as a reason why people were posturing forward, right? That was made for many years. The idea was, well, this is an occlusal problem, and so we need to eliminate the interferences, and if we could do that, get people back in centric relation, that's going to fix that problem. And then in the middle of our training, all of a sudden airway became something we understood a little more, and it started to be, well, gosh, how many people are doing this because they can't breathe? And when we come to this meeting, what's interesting, as I've started to look at all on X cases, many of these patients that were doing these all on X cases, and I'd like you to speak to this, seem many times maxillary deficient. We're having to fight with, do we have these massive, anterior cantilevers to get teeth in the face where they need to be because the jaw was, and is that why they destroyed their teeth?
And a lot of these
prosthetics,
have to be certain thicknesses, and if there's not enough bone reduction, and then you can't reduce certain amounts of bone,
we may be constricting them more sometimes.
And then, yeah, exactly. You may be shoving the tongue back further, and in some ways, one of the surgeons we work with, he said, we're really doing orthognathic surgery on a lot of these patients, and
in acrylic,
and sometimes whenever we jump to a case and we end up finding that the patient is struggling with the prosthetic as we're going through prototypes, we're moving these prototypes out further away from the implant body, and now it becomes a cantilever.
You think there's something to this with that type of patient?
I think there can be. I just I think about all the NXs, all the treatment that I've done, and we're making the box smaller, and now we're putting all these implants into these airway patients, and are we, at the end of the day, we're physicians, we're doctors. We need to kind of be, we have a seat at the healthcare table for a reason, and we need to, empower that. And I think if we're not kind of looking at the total wellness of the patient, I think we're doing a little bit of a disservice to our patients and ourselves. And, we need to get out of that technician mindset. We need to get into the planning and the diagnosis standpoint. And then, at the end of the day, we're not treating cancer. So if the patient wants us to treat a more simple, a less expensive way, a more minimalistic way, then that's their choice. As long as they know and they have informed consent, then okay. Right. What else can you do?
That's right.
Talk about, you mentioned earlier about what's happening to these patients who seemingly have no symptoms. One of the things that's really struck us and learned as we learn more about it is upper airway resistance as opposed to apnea, right, in these patients, because many times these cases that we're treating with more conservative treatments such as SFOT, MARPE, maybe the upper airway resistance patients. So maybe define that a little bit for us, and maybe compare and contrast that to the patient who comes in who's maybe an obvious apnea patient.
So that'll be generally your thin, woman who's fatigued all the time, who's not getting restful sleep, who just doesn't feel like herself. But she's not sitting in your chair with a huge neck and at 300 pounds, and you're kind of trying to figure out how to, where do I fit in this in this treatment plan or this healthcare matter for this patient. And oftentimes they will have nasal flow, nasal resistance problems. They'll have a narrow upper airway. MARPE, I think, in that context would really be, fantastic. So we'll oftentimes put a patient on a high-res pulse oximeter. We need to be a little careful with how we're kind of connecting these dots, and we need to make sure that we get our physician colleagues in line so that they can kind of help diagnose the patient medically, and then we can also support the treatment that we're doing dentally to maybe improve the health care on these patients. I do see a lot of patients being treated for airway problems without a diagnosis, suspected. And I was involved in a lot of these expansion treatments that really went quite wrong because they saw crowded teeth, they saw a small, airway, oral cavity volume, and they immediately, just kind of jumped to expansion treatment. Sleep apnea and airway is a very complex discipline. And all we can really do in dentistry is fix one of the 4 parts, which is the collapsible upper airway, right? So you can't really manage arousal threshold. You can't manage ventilatory control. These are things that are really out of our wheelhouse as dentists, but we need to make sure that we're treating the right part of sleep apnea so that maybe we could have an impact. And if it's a collapsible upper airway issue, and you're going to expand the patient, you're going to bring them forward maybe orthognathodically and so forth, then I think, I think it's never been a more exciting time because you're really managing, a medical diagnosis. And periodontists has never really been involved in these ortho-oral surgery planning. And so I think it's an incredibly exciting time.
We're starting to see some of the oral surgically trained specialists also be trained in the mid-face and how to do mid-face corrections inside the nasal passages. And a lot of the cases that we've been involved in getting people to the right medical people have training that allows them to involve themselves into the nose and airway. And I think that's a key component that we have to involve these specialists. We're also seeing ENTs that have oral surgical training. And these are things that are helping us to really involve people that can help us make the right diagnosis.
We're very lucky in Chicago. We have an amazing team, an interdisciplinary team. One of our team members is Mike Hutz. He's a double-boarded ENT sleep medicine physician who also did a year fellowship sleep surgery at Penn and he actually trained with Mariana Evans. And so, he brings that understanding that most ENTs don't have. The other thing that I think is also helpful is, in the patient that doesn't have a huge sagittal correction, let's say, not sagittal correction, but more of a coronal correction, if you can expand them with dental alveolar augmentation, perhaps that patient becomes a 1-piece maxilla versus a 3-piece, right?
Absolutely.
So now what's more stable?
That's right.
Right.
Yep.
I mean, most of the surgeons would probably rather do a 1-piece if they could, if the conditions were right, and they're not always.
Even surgical procedures that were done a couple years ago, we now know that there's things that can be done less invasive.
Yeah, that's right.
Again, there's many ways to treatment.
Yeah,
but we need to get the right diagnosis.
If you have a periodontist who is interested in this, where do they go to get training? Because that's one thing I know Rick Robley, for instance, it was, I believe, Arkansas. He's done some training, and I think Wilco has done some training. Where would you say is the next step for someone to go if they really wanted to actually see this and then be able to do it?
There really aren't a lot of training programs around to do this. My dear friend Todd Shire in Houston has put on the Institute of Houston Dental seminars, I believe is what it's called, the IHDS. He has a great team, and they put on courses once or twice a year. David Alfie's the oral surgeon involved. John Korotkin is the orthodontist, and they have a really good course that will educate and really kind of, and they're all very airway driven as well. So that would probably be the course I would recommend.
Okay.
It's a deficiency right now. We've talked about it, and we've talked about maybe should I have something in Chicago? Should people shadow?
You should.
We need it.
That's one more thing I need.
I know, right?
No, one more thing.
You have nothing else going on, right? Yeah. But that's I think the big thing that we're trying to because we learn about these things, right? And we see some cases, and we just released a few weeks ago an episode entitled "I Broke My Wife's Nose," which is kind of just because I was the one turning the expander on her MARPE when it actually went. But the idea is, we learn about all this, and we're even doing this in our patients and in our loved ones, and yet there's a lack of training opportunities. And I think are we seeing this trained from what in residency programs even? Is that a thing that is being introduced, or is this still maybe years off from being part of a residency training program unless we're doing, say, fellowships and things like that?
Well, there really aren't any fellowships in periodontics. this has been a journey that I've kind of self motivated to kind of learn,
Yeah.
and I've learned this through other periodontists and oral and maxillofacial surgeons. I mean, one of my mentors, Dan Spagnoli, took me under his wing and really kind of taught me some of the more advanced dental alveolar surgery, and I mean, I can't thank him enough for that. And so it's been a patchwork quilt of a lot of different disciplines to kind of do what I'm doing. I don't think it's really quite at the university levels. I know at University of Illinois we're doing some of that. I'm doing some teaching there with Dwayne Caratu, and we're having some peri-ortho meetings, but it's not really pervasive in the specialty training at this point. But it's an incredibly exciting time because it also expands the team from an auxiliary standpoint. Just because your wife got her nose broken, she also has to learn how to use her tongue, right? She has to put her tongue there, right? And she's got to there's myofunctional therapists. And we also kind of, I just remember seeing a patient just the other day who, is tongue-tied, but, her speech is fine. She has no airway issues. Her airway intake form's all clear. So are we clipping too many tongues just because we see something tied? Are we thinking through this patient really could benefit from a tongue release, but now we need myofunctional therapy. We need, so it gets complicated. And I think if we don't spend the time to really kind of think through and have other team members that can give us some of their thoughts, right? Nobody does everything by themselves.
This is why that we love having conversations with people like George Mandelaris, because it really helps do, and I love the analogy of the patchwork quilt, and that's our journey as well. It takes a lot of travel. It takes a lot of time. Yeah. You don't get paid per se for that, but the reward at the end of this, if you get the right diagnosis and you're doing this in the right manner, it's very rewarding when that patient sets down, because that's ultimately what we're talking about, is trying to improve someone's overall health. Yeah. And it can be unlocking. And we've seen it time and time again.
Life-changing potential treatments. And so it's been great. Thank you for being with us and talking to us today. It's a lot of fun and definitely somebody we're going to be following. And if you've been listening to this out there and you've kind of been challenged to think differently, we hope that you will, first of all, check out what Dr. Mandelaris is doing. Check out the book, because, when you have a book that's titled, this is the procedure, and it's titled, so that's saying
it took 6 years to develop this book.
6-year journey, So we want you to check the book out. And then we also want you to challenge yourself to start finding out more about things like SFOT and MARPE, and just what can we do to learn, again, how to get the right diagnosis and to maybe change people's lives. So it's been another great interview here at the AO 2024. Thanks for joining us. And so for Dr. Mandelaris, for Wes, I'm John, and we are the Dental Guys.
What I was hoping I would get from a periodontist who is passionate about not only what the AO is doing, what AAP is doing, but about trying to create a consensus. I had only maybe come across his name associated with SFOT in the last couple of years, but I don't think I really understood how ingrained he was in the world that you and I have kind of been diving into in the last couple of years, with things like MARPE and SFOT and SARPE, and how does this really affect our practices? And Wes, did it make us buy a textbook? I think I might have.
Yeah, John, we bought a textbook. You're looking at it on the screen right now. The editors, George Mandelaris and Brian Vince, Surgically Facilitated Orthodontic Therapy, an Interdisciplinary Approach. You can actually go to Google Books and just kind of look at like the first chapter or so, and you're seeing it on the screen right here. But I want to kind of just go just past, the intro and the table of contents, which is thick. But what I think is amazing about this is how we start from the beginning, because a key to understanding what you're looking at here is the embryologic development of the jaws. If you're looking at this on the screen, you're thinking, oh my goodness, what are we talking about here? Well, what you have to do whenever you're starting to think about airway and development and skeletal and craniofacial problems is you actually have to go back to how it all starts. How does this develop? and you actually have to go into anthropological evidence. You have to be an archaeologist. You have to be Indiana Jones, man. I mean, this is, I'm telling you, this is an Indiana Jones moment for dentistry. And
well,
maybe
but too, though, when you have somebody who can write a chapter titled Embryologic Development of the Jaws, who's also practicing clinically, that to me is incredibly impressive. These are the people we want to be around. If you look at the chapter list in this book, you're going to see names like, as you see on the screen, if you're watching the YouTube, Colin Richmond. You're going to see one of our favorites, Rebecca Bacau, was able to contribute to this and write a chapter. Jim McKee, who we've heard from at Spear, talking about TMJ and how that might involve your treatment planning. You've got people from all areas of expertise in this field who are contributing to a textbook. When you title something in such a way, surgically facilitated orthodontic therapy, that's a bold way of saying,
well, you immediately think this is like, okay, come on. This is an ortho book that we're going to talk about some kind of like surgery or something and a how-to. And yes, we have a lot of that in here, but also what we have is not really, I would say, a consensus, but what we know now and how to go forward. Now, so why would we read a textbook? Well, it goes back to maybe a podcast a month or so ago where we met with a young dentist and we talked about what is comprehensive dentistry, and you only see what you know. And so what textbooks bring us, and today we can produce a textbook, even though George will tell you that this was anybody that writes
years
a textbook,
in the making.
It's tears in the making. It's a passion project. And what I would say is that this is not something that we're reading in light just to say we read it. We're reading it to acquire knowledge so that we can immediately start to ask questions about our diagnosis and treatment planning so that we may be able to reach out to other individuals, interdisciplinary team members, maybe even look at what protocols we have right now. Are they making sense? Does it line up with what we're seeing here? This is learning about where to go from here. John, you and I had a conversation.
I think, Wes, oh, go ahead. Yeah,
well,
you
and I had a conversation last night, just about, this idea that you can just show up and just do this stuff. And that's just not the case. You can't just show up to work and just do this stuff. If you do, you could and probably are missing the point. And so I really want to encourage people that when we choose a textbook, whether it be Zero Bone Loss Concepts or Surgically Facilitated Orthodontic Therapy or the book that Craig Mish came out with, why would we read that?
Well, and I think, Wes, the thing that, and this is just, you guys know, we're having these conversations, and if you listen to podcasts, if you watch YouTube, people can say whatever they want to say. Right? You can listen to us talk, and you know what? If you trust us, if you know us, I think you would trust us that we actually have read what we're the literature, the basic science of what we're talking about, and we'll also tell you when we don't know. But the truth is, Wes, it's just talk. When someone publishes something, when someone goes to the extent of saying, because here's the thing, if you're sitting there and you have no idea what we're talking about, okay, that's fine. But if you do have an idea of what we're talking about, right, you have somebody that has a high vaulted palate. You have somebody with deficient buccal corridors. You have somebody who may need palatal expansion as an adult. We still don't have a consensus on what can SFOT do versus MARPE versus SARPE when do you use which thing? If you need 2 millimeters, do you use this? Do you use that? If you need 7 millimeters, do you use this? Do you use that? What's the good? What's the bad? When would you do it? What's the tissue type? What's the phenotype? What's the thickness? What's the recession? What's the bone augmentation? What's the male female predilection? Can we open the suture? All these things, we've got somebody who said, hey, I'm trying to create a step-by-step way or a consensus way of thinking about these types of cases. And I will say that is not easy these days when you have a lot of talking heads, and we are one of those that's on there talking, but we are encouraging people like Mandelaris, and we love these types of folks who are coming and saying, yeah, we hear the need for this. So how do we figure it out? We get the smartest people in the room. We write some chapters. We create citations so you can read the basic literature. And then we can, over time, develop a systematic way to treat, Wes. That is what we got to do. And we don't have it yet. And Mandelaris is blazing, I think, a very important path.
I'm really excited about this book. You're going to hear more about it on the show later on this year. One of the titles of part 2, patient assessment and co-discovery, diagnosis and planning the vision. And the roadmap to treatment is being written right now. And in this realm of skeletal deficiencies, skeletal growth deformalities, why are we class 2? Why are we class 3? And some of this stuff is not new, and we forgot it. And I think, John, there's a lot to unpack here, and I'm excited about the future. And so if you're listening to this and you're thinking, man, whoa, where do I even go to start? I tell you where. I tell you where to go, and the dental guys have paired up with Spear Education this year. And it's an incredible deal. So in the description below on YouTube, on Facebook, if you're in Spotify, Apple Podcast, all that kind of stuff, you can go to a Spear seminar. Okay, we're pretty much going to pay for your flight because we're going to give you, Spear is going to give you, okay, because you guys are a listener, a $500 off coupon to an in-person 2-day seminar. So basically, you're flying there for free to take this seminar from Jeff Rausch, Airway Prosthodontics, taking dentistry beyond sleep apnea and advancement appliances. And I think this is a great place to start. You can do that. But there are so many in-person seminars to choose from now. And if you'll go over to Spear and you click on events and you go down to in-person seminars, all these seminars here, innovations in digital dentistry, mastering dental practice management, transforming everyday dentistry, the art of treatment planning, demystifying occlusion, treating the worn dentition. I mean, and keep going on. But if you want to just get a taste of sleep,
yeah, if you want to put yourself in this conversation of knowing, because I guarantee you it will mess with everything you're doing on a daily basis. This is a good place to start, is with Spear. But we just appreciate, once again, the AO for allowing us to be part of the meeting. Thanks to Dr. Mandelaris for being a part of the conversation and pushing us toward always getting better. If you like what the dental guys bring to you, the content we bring, how can you support us? Well, you can like our pages, you can share with your colleagues and friends, and of course, you can subscribe on YouTube so that you get every episode as it's released, so you can be the first one to listen to what's new and what's messing with us. So for Wes, I'm John. This has been another great episode of The Dental Guys.